Collectively, Ashley Graham, Brianna Herbolario, Kristine Penuliar, Katie Vu, and Nicole are the epidemiologists who research syphilis and will be presenting the prevalence of syphilis within adult males in the United States from 2003 to 2018. Syphilis is a sexually transmitted infection that can cause serious health effects such as death if not properly treated. For our presentation, when P and S is used, it refers to primary and secondary syphilis. Syphilis has long been a public health issue, and in 2017 alone, there were more than 100,000 new cases of syphilis reported, more than double the number of new HIV diagnoses. Now I will go over the extent of the problem, first discussing morbidity and mortality. Morbidity is the development of an illness within a population. In 2017, the Centers for Disease Control and Prevention estimated an average of 9.5 diagnosed cases per every 100,000 people. This is a 10.5% increase from the previous year in 2016, where there was 8.6 diagnosed cases per every 100,000 people. The mortality rate is the number of deaths within a population in a given time or location. The mortality rate of syphilis can range from very low to very high depending on treatment. Syphilis can be treated very easily by penicillin injection, and afterwards it can no longer continue to harm a once infected individual. But if syphilis remains untreated, there can be an 8% to a 58% mortality rate, with the highest rates among males. For the economic impact syphilis has on the United States, it can vary depending on what type of syphilis needs to be treated. The direct medical costs of syphilis, including primary, secondary, and tertiary syphilis, are about $715 per each case. The indirect costs are about $140 per case. The medical costs per each case of congenital syphilis, on the other hand, are much higher. The direct medical costs are about $8,424 per case, and the indirect costs are about $75,000 per each case. Discussing the temporal variation, rates of syphilis have fluctuated up and down throughout time. Starting back in 1941, the number of reported cases of syphilis had reached epidemic numbers. Then, in the 1990s, there was the lowest number of reported cases of syphilis ever. And finally, starting in the year 2000, syphilis rates have risen every year since. Geographically, syphilis has had the highest rates reported in the West, with 13.2 cases per 100,000 people, and has the lowest rates in the Midwest, with 6.2 cases per 100,000 people. In California especially, the number of cases of primary and secondary syphilis and congenital syphilis are the highest in the nation. From 2012 to 2015, the number of cases of congenital syphilis had quadrupled in California. In terms of endemics, African American men are far more likely to have syphilis than any other race, with the greatest disparity being 4.5 times more likely than non-Hispanic white men. Looking at this graph that shows the rates of syphilis by region, you can see that syphilis rates were lower in 2008 and have increased each year until 2017. The West used to have lower rates of syphilis and has since passed the rates in the South and now has the highest rates of syphilis in the United States.
Hi everyone, my name is Katie Vu and I'll be covering the second part of syphilis, agent of disease, signs and symptoms, and the mode of transmission. As you can see, both graphs shows the rate of reported cases among females and males aged 15 to 44 in the United States from 2008 to 2017. This disease has been increasing for the past few years, and in 2017, female ages 20 to 24 are reported to have the highest ranking of syphilis, and as for males, aged 25 to 29. Agent of disease. Syphilis is a sexually transmitted disease that is caused by the bacterium known as Treponema pallidum. This bacterial agent can be transmitted from person to person via direct contact. And if this disease is left untreated, it can cause long-term health problems, and a person who is living with syphilis has a higher chance of acquiring HIV or AIDS. Moving on to signs and symptoms. Syphilis develops in 3 stages, and the signs and symptoms vary within each stage. Primary syphilis is the first stage of syphilis. In this stage, an individual can develop a small sore which is called canker. These sores appear at the location where syphilis enters the body, which develops within 3 to 4 weeks after the exposure, and there are no signs and symptoms presented. The second stage includes rashes that can eventually cover the entire body, but these rashes do not cause any irritations or itchiness. There are many cases where some experience hair loss, muscle aches, fever, sore throats, and swollen lymph nodes. In the late stage of syphilis, around 15 to 30% of people who are infected and did not get treatment will develop complications later in life, such as damages to the brain, nerves, eyes, heart, liver, bones, and joints. It is very important to get tested for syphilis to avoid all of these complications and to better protect yourself and others around you. Mode of transmission. The bacteria enters into the body through minor cuts or abrasions in the skin or mucous membranes. And although there are many modes of transmission, the most common route is through unprotected sexual contact with an infected person. And this could be in any form such as vaginal, anal, or oral. Other routes can include sharing needles and pregnant mother passing this disease to their unborn child.
Hi, my name is Kristine Penuliar, and I will be presenting information on syphilis regarding prevention, host factors, and environmental factors. So there are 3 levels of prevention: primary, secondary, and tertiary. The primary level of prevention addresses the specific protection from the infection. In this case, abstaining from sexual intercourse or using a male condom during vaginal intercourse are both examples of primary level of prevention of syphilis. The secondary level of prevention is targeted at hindering the progression of the infection. To reduce the progression of syphilis, one should get lab tests to confirm the infection. This is because sores from syphilis can be dormant. The tertiary level of prevention focuses on limiting disability from the disease. In this case, the antibiotic penicillin acts as a treatment for syphilis, and the antibiotic is usually administered as an injection. While syphilis continues to be an epidemic, it is concentrated within certain personal characteristics, such as gender, age, and race. As for gender, men seem to have higher infection rates than women. There have been 50% more syphilis cases among men than women, which only increases when looking at the men who have sex with men population. As for age, the highest syphilis rates among women were within the ages 20 to 24 and 25 to 29 for men. As for race, racial minorities seem to have higher infection rates, specifically the African American and Hispanic racial group. Up next, environmental factors, specifically geographical location. During the year 2016, it was documented that Western states had the highest rate of reported syphilis cases at 11.4 cases per 100,000 population, showing a 20% increase from the previous year. This figure shows the rates of reported syphilis cases by state. You can see here that the states with the highest rates are concentrated on the West in states like California, Nevada, and Arizona.
Hi, my name is Ashley Graham, and I will be presenting common gaps in knowledge about syphilis, what we can do to fill in those gaps, and further research that can be done to improve the surveillance. So common gaps that I've seen are in the gender category, particularly homosexual males. Since 2000, syphilis is known to be highly vulnerable to the homosexual male population. In fact, enhanced surveillance data has shown that 50 to 60% of homosexual men who are infected with syphilis are also affected with HIV and AIDS. When analyzing data for syphilis, it has become difficult to evaluate and is very limited because not many people are getting tested after getting tested twice, despite the protocol that HIV and AIDS has that someone should get tested every 3 to 6 months. And this is due to often these men are in fear of getting or being discriminated, or they feel that they get poor health quality care, so they feel the need not to return. So what can be done to fill in those gaps? Well, always the usage of safe sex methods to avoid STDs, but most importantly, interventions. Rates of syphilis are high due to unsafe sex and having multiple sex partners. So interventions are needed for syphilis victims. In the past, interventions have shown to have little impact on syphilis victims because their interventions were too short. Therefore, there is a need for a meaningful evaluation for interventions that start to decrease the rate of STDs. There is also a need for quality healthcare regarding STDs. Primary care practitioners can help endorse a good relationship with their patients in order to increase their awareness about syphilis screenings and to offer assistance to help cope with the infection. So this will create a more gay-friendly primary care center or a friendly care like environment so that they feel comfortable enough to receive treatment. So suggestions for further research. Well, syphilis prevalence data is necessary to be used to access the number of specific screening activities performed by doctors treating or testing for syphilis, and to identify the number of new cases detected in relation to the number of screenings tested. Also, having syphilis prevalence monitoring at local, state, and national levels can be used to monitor and maintain disease burden and trends. So this can be able to identify the target populations that are susceptible to high rates of infection and to analyze case report surveillance data. In areas with considerable morbidity, surveillance data needs to be analyzed on a monthly basis to supervise changes in incidence or new patterns of diseases. And also, there is a need for cases to be reviewed. The monthly overview can be a routine process that will allow doctors to monitor changes in incidence or patterns of disease. Overall, records should be evaluated by categories such as demographic and risk behavior characteristics, including gender of sex partners.
Hi, my name is Brianna Herbolario, and I will be doing the conclusion and a review of the epidemiological terms within this presentation. In 2006, the United States devised a national plan to eliminate syphilis. Syphilis is easy to detect and diagnose, and so the United States, up until 2013, had a plan to eliminate this sexually transmitted infection at the borders of the country. The plan involved different strategies, such as the development of a syphilis outbreak plan, as well as an enhanced health promotion. However, this plan did not work over time as there was still an increased number of cases with primary and secondary syphilis. There is also a need for a syphilis vaccine, as previous research attempted to develop a vaccine, but none were proved to be successful. The syphilis epidemic continues to fluctuate over time, which means it is necessary to reduce the incidence to further decrease the linkage between syphilis and also HIV. Vaccinations would help reduce the incidence of syphilis and would also reduce the linkage between both syphilis and HIV. There are antibiotics, such as penicillin, that help in treating syphilis. However, the public health goal is to prevent syphilis from spreading in order to reduce the morbidity and mortality rates of the infection. Finding a vaccination for syphilis would be cost effective, as it would provide a better source of prevention rather than continuously providing medications and antibiotics to treat the diagnosed cases of syphilis. Furthermore, there is also a prominent increase in syphilis morbidity for men. Even more so, there is an increased prevalence with men who identify as bisexual, gay, or have sex with other men. And this could be seen in the following chart. It is shown that men who have sex with other men have a higher distribution of primary and secondary syphilis, with about 52%, in comparison to men who have sex with only women at about 15%. So what would our group do with the $100 million for syphilis? As stated before, there is a prominent need for a syphilis vaccine, as the public health goal is to prevent syphilis from spreading in order to reduce the morbidity and mortality rates of infection. With the proper funding, the portion of the money could go towards public health organizations as well as partnerships to improve public health interventions and screenings for syphilis. We could further enhance the screenings for syphilis and further provide better health facilities to reduce the incidence. Lastly, as stated by Ashley Graham previously, we should use this money to increase surveillance data to review the patterns of syphilis morbidity across the United States. And these are the current epidemiological terms that we have used within our presentation.
And then these are our references. Thank you guys so much for listening.